Hello, Yat She Dominic Clichee Yinishe, Senajini Anishle, my Deskini A Bushachin, Kenya Ani A Deshache, Petani A Deshanele. Hello, my name is Dominic Clichee, and the title of my project is called Identifying and Prioritizing Factors that Influence Missed Appointments in a Rural American Indian Healthcare Facility. Before I begin, I would like to provide some background and context of my site location and how I got to return back to my reservation and my community. In 2018, I passed my comprehensive exams and shortly after moved from Tucson to Fort Defiance, Arizona. The site that I'm actually located at is 8 miles from where I grew up. And to provide a little bit of context, I'd like to share two more unique things about having the opportunity to work in my community. The first is a quote by Chief Blackout. Everything an Indian does is in a circle, and that is because the power of the world always works in circles, and everything tries to be round. The sky is round, and I've heard the earth is round like a ball, and so are all the stars. The wind in its greatest power whirls. Birds make their nest in circles, for theirs is the same religion as ours. The sun comes forth and goes down again in a circle. The moon does the same, and both are round. Even the seasons form a great circle, and they're changing and always come back again to where they were. They call this the nation's hoop. And I think it provides a great context that the Western Public Health Training Center has provided me. It provided me an opportunity to return home and to provide public health technical assistance. The next story and unique thing about the context of working on the Navajo reservation is a story of what Navajos do with their babies' umbilical cord. They say that parents should bury their children's umbilical cord near the home so that the child will always remember home and be able to contribute positively to the culture and society. So they have this little story about me, about the public health nurses here. They say that my parents may have lost my umbilical cord at the hospital because I returned back here to Tsehootsooi Medical Center to provide public health technical assistance. The site where I am located is the Fort Defiance Indian Hospital Board Incorporated Tsehootsooi Medical Center. The organization is a Public Law 93-638 organization, otherwise known as the Indian Self-Determination and Education Act of 1975. This act authorized the Secretary of the Interior and the Secretary of Health Education and Welfare and some other government agencies to enter into contracts with and make grants directly to federally recognized Indian tribes. So this means that the tribes would have the authority for how they administered the funds, which gave them greater control over their welfare. So the Tsehootsooi Medical Center is one of these 93-638 facilities, and we receive grants to provide healthcare services for 16 communities in northeastern Arizona. The division that I am located in is the Division of Healthy Living and Outreach. It includes 4 departments: public health nursing, health promotion, disease prevention, public health nutrition, and wellness and fitness. My dissertation project, the main reason that I returned home, is to conduct logistic regression to identify significant factors found in the electronic health record. More appropriately, it's identifying and prioritizing factors that influence missed appointments in a rural American Indian healthcare facility. Returning back home to the reservation allowed me to integrate the cultural knowledge in addition to the formal Western education knowledge, such as the maternal and child health assessment and program planning, and one of the quality improvement projects here known as Plan, Do, Study, Act. So I'll go with the Navajo wellness model first. It begins in the East, Nitsahakes, thinking. This is where goal setting, visualizing, developing ideas, intellectual development, and becoming innovative happen. Then on the right-hand side, Nahat is analyzing, understanding, becoming creative, and identifying resources. On the lower bottom is Ina, where you actually do practice and living, where you implement the project. And then Sihasin, reflection, otherwise known in the Western education as evaluation, and really reflecting on the whole entire process of going from thinking, planning, doing, and reflecting. As you'll see, I highlighted each of the respective areas with the project implementation area. So project proposal development belongs in the Nitsahakes, proposal defense in Nahat'at, so you're planning to do your project, and Ina, where we're actually collecting the data doing the data analysis and developing the logistic regression model. On the reflection side, looking back at the entire process to recommend an intervention based on the results. And so essentially, I'm doing an assessment on the factors and influences of the no-show rate. How does that fit into maternal and child health assessment and program planning? Well, again, we're going in a circle. Health problem assessment, health services needs assessment, selection of interventions, constructing a logic model and setting objectives, program implementation and evaluation, similar to the Navajo wellness model. Here within Tsehootsooi Medical Center, we have a quality services department that has this as plan, do, study, act. They're proposing a change idea and how it will be tested. So I'm planning to do the assessment, then I collect the data, analyze the data, and eventually provide a recommendation on an intervention to share financial reflections and hopefully improve the missed appointment rate. My project background. So the no-show rate in some clinics here on the Navajo Nation, is specifically in Tsehootsooi Medical Center, can be as high as 25%. In the pediatric clinic, it's 20%. I chose to do my study at the pediatric clinic because they have the most reoccurring appointments out of all the clinics, and they also, my degree is in maternal and child health. According to the American Academy of Pediatrics, they recommend 16 periodic reoccurring appointments from birth to age 5 years old. These appointments include screening assessments, immunization, education service, and addressing any parental concerns. So on the health side, we know that if individuals make their appointments, so these are individuals that have a low no-show rate, they have better health outcomes. On the administrative side, the Office of Management and Budget has a reimbursement rate for Public Law 93-638 facilities and other Indian health services of $455 per outpatient visit that have to be greater than 15 minutes. In 1 month in the pediatric clinic, there are just under 1,900 appointments per month, with 381 of those being missed appointments. So the average is around 20%. If you multiply that 455 per outpatient visit by the number of missed appointments, there's about $173,355 in opportunity cost and missed reimbursements. So on the administrative side, they're also being impacted. In addition, there are workflow disruptions caused by missed appointments. This also lowers provider productivity and also can lead to bottlenecks. Here are the methods that I will use to look at the factors and influences of the no-show rate. I will be analyzing de-identified secondary data. This means that it would not include any personal health information such as date of birth, medical record number, or social security number. So I will get a de-identified data set and I won't have access to the coded data set. This helps me to pass the IRB human exemption. So what I'm going to look at is the pediatric patient encounters. So those that are 0 to 18 years old from January 1st, 2017 to December 31st, 2019. My no-shows will be defined as the dependent variable. So I will use 0 for made appointment, 1 for missed appointments. And the no-shows are defined as a patient who did not keep the pre-scheduled appointment at least 24 hours ahead of the appointment time. Appointments that I will include in my analysis will be with a medical doctor, a nurse practitioner, or a certified midwife. Further, only the no-shows and successful appointments will be included in the final logistic regression model analysis. Rescheduled appointments and canceled appointments will not be included in the final analysis, but they will be included in my results as descriptive statistics. So looking at the averages of ages for the canceled missed appointments, or another example would be the average age of those that rescheduled their appointments. So I'm only going to be looking at descriptive statistics for rescheduled and canceled appointments, whereas for the no-shows, I will look at complete logistic regression modeling. For all appointment types, to ensure appointment independence, the last appointment for each patient will be used in the logistic regression analysis. To look at these variables independently, I will use chi-square analysis for categorical variables and t-test for continuous variables. The direct variables that I will get from the electronic health record include age. Again, this will just be a category, a number, not the date of birth. Gender, location of home, chapter community residence, address, type of insurance, number of active problems on the problem list, and type of problems listed. For the parent of the pediatric patient, I will collect data from the parent category listed, if single or both parents there, same address as the child, so a yes or no, preferred language, age of the mother, age of father, number of household members, type of insurance, employment location, number of active problems on the problem list, and access to the internet. Indirect variables that I will get from the electronic health record include location of home, whether it's rural and in town, type of housing, whether it's homestead, low-income housing, private neighborhood, the miles from location of the home to the hospital, type of road to the home, is it dirt, gravel, or paved, type of home, apartment, home, trailer. In some cases, we have the Navajo Housing Authority has subdivisions, and also household income, which will be categorized. The outcomes from my project include a health problem assessment, health services assessment, an intervention recommendation with a logic model using nominal group technique and the logistic regression model itself. The impact that my project will have on this community, it would be a guide for replication in other clinics. So that other clinic that has a no-show rate as high as 25% is the diabetes clinic. We could use the same analysis for other clinics that are on location here at Tsehootsooi Medical Center. So it could be shared with other clinics. It could be shared with other service units in our area, such as those in the Gallup service unit or the Chinle service unit, which is also located in northeastern Arizona. The results will be shared with the Navajo Nation Health, Education, and Human Services Committee, which is a part of the legislative branch under the Navajo Nation Council. My project could be used as an application for the next round of Patient-Centered Outcomes Research Institute Award, or PCORI grants. My project will also meet CMS, the Center for Medicaid and Medicare Systems Quality Improvement Project, that could result in increased reimbursement for our facility. A health problem assessment report, a health services assessment report, and a final report. The logistic regression model can be used by other hospitals operating in a similar context using the federal government electronic health record system to identify who is likely to miss their next appointment. So this model will take those variables that are found to be influences of the no-show rate, and the clinic can use this model, input the variables, and by the end of the appointment, they can model and identify who is likely to miss their next appointment, and they can implement the intervention that is recommended. So I'll recommend an intervention to address the no-show rates using results from the formative assessment and the report. During my funding time period with the Western Region Public Health Training, we had the COVID-19 pandemic. The first case happened here on the Navajo Nation on March 29th, 2020. And indirectly, one of the benefits of this opportunity that the Western Region Public Health Training Center has provided is that I was one of the only experienced epidemiologists that was specifically employed or doing my project here at the Tsehootsooi Medical Center. There are other epidemiologists here on the Navajo Nation. However, they work for the entire Navajo Nation. It was the first time that an organization has had someone with epidemiology experience, and that came as an indirect result of funding from the Western Public Health Regional Training Center. I also assisted in directly responding to any outbreaks. I also helped with the rapid response teams for testing and vaccination. I led the monitoring, evaluation, and quality team for the Incident Command Center. So I tracked all the cases, clusters, and local outbreaks and how to respond. And right now, we're also tracking vaccination rates for each of the communities. The Western Regional Public Health Training Center financial assistance has impacted my life significantly and has helped me move forward with my project. In February 2020, I received internal institutional review board from Tsehootsooi Medical Center. Then in March 2021, I passed my proposal defense. Although it was a little bit delayed by COVID-19, I did pass my proposal defense last month. I also am on the agenda for the Navajo Nation Human Research Review Board. My application was submitted earlier this month in April 2021. So I will be able to present and hopefully move forward with that. The University of Arizona Institutional Reward application has also been completed. So my next step is that INA, doing the actual data collection, if you remember from the Navajo Wellness Model. In the future, I can keep the Western Regional Public Health Training Center updated and present my project when it is completed. Further, having that ripple effect again and always going in a circle, the Western Region Public Health Training Center financial assistance has allowed me to be a site preceptor for a future Master of Public Health professional. So right now I'm a preceptor for a Master of Public Health student that is working on a health communications assessment under my supervision. So it left a waterfall or a ripple effect that eventually led to further success and further rural public health training assistance. In conclusion, I would like to thank my advisor, Dr. Taryn, my site preceptor, Leah Earlby-Gay, one of my friends that also helped me and is a great role model for me, Dr. Michael Tutt. I'd like to thank the FDIHB Incorporated leadership for allowing me the opportunity to be here on location on the site. And also I'd like to thank my community. Thank you. Okay.